we have been talking with Ellis, Dr. Martin Ellis, about to prevent the thrombotic events in MPN, which I think you all four of you know, very big specialists in this, and I think it's something very important for us, especially PV patients, that we can prevent it. So, can I give you a word to that you can start on that?
Is this working? Yeah.
Yeah.
So this is clearly one of the really big issues in MPN management, and as I think Dr. Fox mentioned earlier, it's particularly important in PV and in ET. It's also important in MF, but perhaps to a slightly lesser extent, and that has to do with a number of different factors. The very nature of the disease, as being driven by one of the particular driver mutations, is going to be impacted in terms of its thrombotic potential. And just to give you the headline, it's the JAK2 mutation that we think is particularly important in causing a thrombotic predisposition among patients. MF patients tend to have other problems that overshadow the thrombotic problem, but even in MF, there are more thrombotic events that occur than we would expect in similar patients or similar individuals in the general population. And just to define thrombotic events, because this is a technical term, we're talking about blood clot formation either in large blood vessels, which can be veins or arteries, or in small blood vessels. And when we have a large blood vessel that is obstructed by a blood clot, if it's an artery, then we'll have diseases like cerebrovascular events or stroke, put simply, or a mini stroke, which is called a transient ischemic attack, or a TIA. And if it happens in arteries in the heart, that's a myocardial infarction, or what's commonly known as a heart attack. And really, blood clots can occur in other arteries as well, and depending on which arteries in the body they occur, we'll have the clinical event that is a consequence. So an artery in the abdomen, in the belly, that gets occluded can cause the bowel, the intestine, not to receive blood, and that can cause damage to the intestine. It can occur in the artery to the kidney. It quite frequently occurs in arteries leading to the spleen, and all of these tissues can be damaged and cause the relevant clinical scenario. When blood vessels that are veins get occluded, so the disease that occurs is deep vein thrombosis, which is typically something that occurs in the leg, but it can occur in other veins in the body as well, and quite commonly in MPN patients, this can occur in veins in the abdomen, so the vein of the liver called the hepatic vein, or the vein that joins the liver and spleen, which is the portal vein, or the vein of the spleen, the splenic vein, and other veins in the abdomen that drain blood from the gut, from the intestine, can be occluded by these blood clots. So that's a general overview of a thrombotic event. And as you may imagine, some of these can be catastrophic and life-threatening. And it's in fact the main cause of death that we have in patients with chronic phase myeloproliferative neoplasm. So it's very, very important that we address this potential complication. A large number of patients will be diagnosed with an MPN on the basis of one of these thrombotic events. So we'll meet these patients after they've had their blood clot and their physician has either done an evaluation or suspects that there may be an MPN that's underlying. And so we get the patients after they've had their blood clot or thrombotic event, so to speak. So the focus on prevention is quite high, and we know from clinical studies that have also been discussed earlier today that one of the main ways of preventing a second blood clot or even a first blood clot is to provide adequate treatment for the MPN, and in PV that implies reducing the hematocrit to the target level of 45%. In essential thrombocytosis, it's decreasing the platelet count, again, according to the patient's risk profile that has been discussed, and adding in an antithrombotic agent, which will usually be aspirin in a particular dose. And that's what we'd call the low-hanging fruit. That's fairly easy to do. We have guidelines and recommendations by numerous international and national societies as exactly how to go about doing it. And we just got to make sure that patients are appropriately treated. But then there's sort of the background to all of that, and that is this underlying thrombotic tendency that persists. And here there's been a lot of work done recently looking at other ways that we can manipulate the thrombotic tendency that these patients have, and we discussed a little bit of that earlier as well. Diet. Turns out that appropriate diet, the Mediterranean versus the, no offense, but the North American diet makes a difference. This is true as well, not only for MPN patients, but just in general. And this is something that is getting more attention in clinical practice. And I think another very, very interesting aspect of thrombotic tendency in MPN, and with this I'll end and maybe just leave it as a provocative statement, which we can perhaps discuss during the coming time, is the role of inflammation. So we know that MPN is an inflammatory disease as well as being a genomic or a genetic disease. And there's been a tremendous amount of knowledge that's accumulated in the last 4 or 5 years about the interplay between all of these mutations that we've spoken about, the driver mutations, the passenger mutations, their influence on inflammation on a cellular level, not on the kind of inflammation that we think about, that you have a sore joint or you have inflammation of your skin that you can see and is painful. This is sort of biological inflammation, which is not something that the patient actually feels. And then that is, in a reverse direction, also very important, because inflammation may in fact affect the mutations that MPN has in terms of additional mutations, driver mutations, the strength of the mutation, the allele burden. So there's this interplay between the milieu, the stroma of the bone marrow in particular, and inflammatory processes that occur there, and the hematopoietic cells themselves, the stem cell and the progeny of the stem cells. And this inflammation also plays out in the vascular system, in causing a tendency to thrombosis and to a thrombotic potential. So I think it's really tantalizing to speculate about the role of anti-inflammatory drugs, which has been done, again, not only in MPN patients, in cardiovascular disease in general, but with a special emphasis on this inflammatory background that MPN patients have. What might the role be for anti-inflammatory drugs? And I'll just give you some names of drugs that are touted to be of use. They're drugs that target a particular cytokine, a chemical called interleukin-1. So they're interleukin-1 inhibitors, which have been used successfully in certain patients with cardiovascular disease. And then there are other much simpler, older anti-inflammatory drugs like colchicine, which is typically used for patients with types of arthritis, gout, and other types of arthritis as well. Colchicine may have a role. And then the huge market that we have for statins, for the cholesterol-lowering agents, which are part of the statin group. These also have anti-inflammatory properties, and one can speculate about other drugs. Some of these would be drugs that would be repurposed to try and target the underlying chronic low-grade cellular and biochemical inflammation that occurs both in the bone marrow and systemically in patients with MPN. So I would say that for me, looking at beyond the classical way of preventing thrombosis in MPN patients would be something that we should be focusing on in upcoming research.
Thank you very much, Martin. Is the sport helping also to avoid thrombotic events if you're more active physically?
Yeah, I mean, I think that's very intuitive. I'm not sure if my colleagues can speak more specifically to data in MPN patients, but I know that Ruben and his group and others have accumulated a lot of data in looking at various health-related or health-enhancing activities. I mean, the classic one I think that we learned about from his group was yoga, for example, and various online activities that people have participated in. I'm not sure about sports specifically, but there's been a very recent study, by the way, just looking at sport in general as a mechanism to combat depression. Turns out that sport, if you can keep it up, is as efficient and as efficacious as taking big-time antidepressant drugs. So I would say that sport in general is good. Certainly it would have a potential to deter or avoid thrombotic complications, certainly the arterial ones.
So a lot of information there, Martin. Maybe I'll just make a couple comments. One, without question, the more fit you are, probably the better off you are in terms of your health, and certainly including thrombotic risk. I think the important thing to think about with thrombotic risk of blood clots, is that one, everyone has a risk of blood clots. Every child, every adult, and the older we get, we can have a higher risk of blood clots. And things that add to our risk of blood clots are things such as immobility, certain types of surgical procedures such as hip replacements or knee replacements, long air travel where we don't get up during the flight and walk around, sometimes being on hormone replacement, smoking. So there are many things. So we all have some risk. People are more prone to have blood clots when they have pregnancy, etc. The way to look at an MPN is that it can increase that risk. And part of the different treatments that we talk about, whether it's controlling the number of red blood cells through medicine or phlebotomy, whether it's aspirin, whether it's medicines to lower the counts, are to try to lower that risk closer to what it is normally. So nobody is 100% protected against blood clots, because anybody can get a blood clot. But our goal is to try to get you much more like it would be for typical situations. Now, it's important to realize there are things that can increase that. All of those things that increase it in other individuals increase it if you have an MPN. Higher risk during pregnancy, travel, things of this nature. So the things that are important to remember is that when you're in those situations, just like others, it's good to try to do what you can to prevent blood clots. If you have a 12-hour flight, and you're in a middle seat, one, God help you, but two, to try to drink plenty of water, and
you have to go a lot to the toilet.
Get up every couple hours. Likewise, if you're having particularly orthopedic surgery, other things, it's good stuff for them to know. We know through efforts of many of our colleagues, that there are special precautions we take during both pregnancy and the time of delivery to try to decrease that risk. So without question, fitness helps without question. Being a non-smoker is very helpful. So if anyone is a smoker, realize it's a very difficult thing sometimes to get off of tobacco use, but that is probably one of the most modifiable risk factors. Hormone replacement is something that has to be done with a great deal of discussion with your physicians and other things.
Thank you very much. Thank you. Yeah.
Thank you. With respect to the thrombotic risk, I heard about research being done by Brandy Reeves about the release of tissue factor with neutrophils. Are you familiar with it? And could you elaborate a little bit on it?
So Brandy is one of my new neighbors in the state of North Carolina, just down the road at University of North Carolina. I'm in the western part of the state in Charlotte. For those that have not been there, it's a lovely part of the United States. And her lab is, again, looking at different potential models. There long has been a sense from clinical data that an increase in the number of white blood cells, helps to increase the risk of blood clots. And I think her work is interesting. I don't think the exact mechanism is still 100% solved, but I think that this is one potential explanation, as to, why do the white blood cells contribute to that. What we don't know for certain is, does decreasing the white blood cells reverse that risk? We assume so, but we don't know that beyond a shadow of a doubt. We also don't necessarily know what the target level should be. So there are individuals that have a high white blood cell count, and all things being equal, we may want to lower the white blood cell count, although we don't know for certain that that is necessary for everyone. There are individuals that have had a blood clot who have still a normal white blood cell count, and we don't know, is it important for us to decrease that further? So there are so many questions, in part because we don't exactly know how they are tied. So if her work or others help to demonstrate what the actual target is, perhaps it may help to give us more guidance as to what level we should be aiming for and things of that nature. It comes up in particular in the setting of people that have had blood clots in the liver, or what we call Budd-Chiari syndrome, where we feel they're at high risk of blood clots, but their blood counts don't tend to be as high as others. And we sometimes struggle to figure out what is our target in terms of lowering the blood counts.
Can I add one thing? So, Mesa's slide, I think it's not just only the member, but their activity, because we can, after acquisition of mutation, these cells, including platelets or white blood cells, neutrophils you mentioned, their propensity to get activated. So I think they are more prone to get activation than the healthy neutrophils or platelets. So that's the one reason. Even the patients who have normal white blood cells or platelets anyway high, but white blood cells like neutrophils, so their propensity to get activation is much different if they have the mutation. So that is one. Whether tissue factor or other factor, yes, there are probably multiple factors can contribute to that.
I'm trying in English. My daughter is 9 last year, and she has PV. Vale. And she has PV. Last year, she has a very, very extensive portal vein thrombosis. Her labs at that time were fine. Only the platelets were about 700. And she has a very, very big spleen. And my question is, how can we know that the things are fine? So that her labs are fine? Because the hyperesplenism, ¿no? El hiperesplenismo is associated with a... Bueno, a ver, no sé si sigo en castellano mejor. Yo quiero saber si hay una hemodilución asociada al hiperesplenismo, o sea, ¿cómo podemos...?
Un momento.
Sí.
Everybody should put his earphones on and you can listen in English.
Sí,
yeah?
porque no voy a poder.
El castellano yo puedo entender.
Vale, genial, qué bien.
Pero catalán
no. Vale, no, tranquila.
Vale, sigue, adelante.
Bueno, entonces eso, tengo una hija de 9 años que tiene policitemia vera y el año pasado tuvo una trombosis portal muy, muy, muy extensa con una cavernomatosis y entonces yo quiero saber cómo podemos saber que las cosas van bien, ¿no? Que su analítica está bien, porque un poco lo que nos han comentado es que claro, que debido al hiperesplenismo hay una hemodilución asociada y que en realidad no podemos saber cómo están las cosas con la analítica, ¿no? Realmente, cómo está su médula, cómo está... Lleva un año con Pegasis y su carga alélica ha disminuido, pero hoy ya he visto que eso no sirve de mucho. Yo estaba muy contenta con eso, claro. Y entonces quiero saber ¿cómo estamos seguros de que no hay riesgo trombótico ahora? Y por cierto, claro, también la pregunta es ¿por qué? ¿Por qué una niña de 9 años con una dieta súper cuidada, que no come dulces, que hace ejercicio, por qué tiene una trombosis portal así?
So, certainly open up to my colleagues, but I'll comment because we did a study specifically for portal vein thrombosis in the MPN Research Consortium. So one, you have several questions in there. One, there's nothing your daughter did to deserve having a portal vein thrombosis. There's nothing related to diet or exercise or really anything. We know that having PV in particular really increases that very specific type of blood clot. If they look at everyone that has had portal vein thrombosis in different series, at least 40% or more have P-Vera. And there's speculation that those they don't find the P-Vera, there's probably some of those that probably still have P-Vera. So there's a very specific thing that we don't fully understand as it relates to the lining of those blood vessels in the liver and why that particular type of blood clot occurs. Her having had that blood clot, you're struggling with what we have struggled. What is the target for medication? Because frequently the blood counts are not elevated. And that's in part because the effect of the portal vein thrombosis suppresses the blood counts to some degree so that they are not elevated. In the clinical trial that we did, and this was in adults, there is no data for children. I wish there were, but there really is no specific data for children. There's a limited number, and I think she's been a speaker at this event in the past, Nicole Cousin in Cornell, who's studying this, but the number of patients are so small, it's very difficult to do any sort of definitive study. In adults, we aimed to try to get the blood counts toward the lower limits of normal. Still normal, but a white blood cell count, if normal is 4, of 4 to 6. Platelets of 200,000. If 400,000 is normal, and 150 is the lower level, as well as trying to control the hematocrit. We still do not have a good blood test to tell us, are we exactly on the right track? I wish that we did, but there is that uncertainty. We do think that helps. That in that study, and there was not a control group, was a helpful study. It seemed reasonable. We also, use the other tools of the blood thinners, like warfarin or Eliquis or other medicines. None of us exactly know when is the right time to stop those medicines. So many of us, particularly with that blood clot, may leave that medicine ongoing as long as it's not seemingly harming the individual. So there is clearly uncertainty. That being said, I think there have been many patients that have been on interferon with portal vein thrombosis, who have done well, who have not had another event. The good news overall is that the majority of MPN patients, once they're diagnosed and once they're adequately treated, the number of people that have a second event or have a first event that never had an event is relatively small. The greatest risk of a blood clot with an MPN is before someone has been diagnosed. And frequently that is the cause of the diagnosis. So I know that doesn't answer what should be our goal, but maybe we will make discoveries that will help guide us further in the future. Clearly there are many efforts to try to understand why do people develop blood clots? Are there blood markers we can track? But at the moment it's still uncertain. But other thoughts from my wise colleagues at table B?
I do think there's something different about patients with MPNs who have these type of clots, like portal vein thrombosis, because they do typically often will present with normal counts, and this will be the presenting events or close to normal. And I think all of us struggle with this question about how to treat them. And I think Ruben just described what most of us will do is to treat it and to just try to keep the counts as normal as we can and on the low side. And then the question of blood thinners, of course, I think is another difficult question, especially, with someone who is young and how long do you keep them on this? So, unfortunately, we don't have great answers for you, but I think a lot of research is going on specifically looking at these patients. If we find what is that factor that makes people thrombose specifically in these abdominal vessels, because they do tend to be younger. I think that is the one presentation that we know is that these patients tend to be younger. If we figure out what that is, I think we'll be able to deal with it better. But for now, this is exactly what is done, is that we treat them with cytoreductive therapy. I think typically interference and anticoagulation, blood thinners, and patients do well. Anyone else?
Yeah, I agree, obviously. I think one of the questions that as a community we need to answer, I'm interested to hear what my colleagues think about this, is the type of blood thinner. We mentioned the warfarin, which is a medication that you have to take while being monitored to see that you're taking the right amount of medication. It's a medication that's very difficult to get right because there are a lot of interactions between the drug, the warfarin, and food in particular, and other medications, including antibiotics that we all need to take from time to time, and intestinal upset like in gastroenteritis, diarrhea. And that's as opposed to a new class of anticoagulants, so-called direct oral anticoagulants. The drugs are apixaban and rivaroxaban and edoxaban. Those would be the three commonly used ones, also known as Eliquis and Xarelto and Lixiana. And those are very easy drugs to take. And they don't need laboratory monitoring. They don't have anything in the way of drug and food interactions, and very, very few drug interactions. But we know for sure that they're safe and appropriate to use in diseases like portal vein thrombosis and Budd-Chiari syndrome. There are data that have accumulated showing that they're effective, but I don't think that anybody is entirely convinced that these drugs are safe. We have many, many more decades experience use with warfarin rather than with these new drugs. And I think that could be a game changer for these patients, especially for younger patients, where it would be easier to use these drugs and you could use them for the long term very easily, because they're really easy medications to take and they have a very good safety profile. So I think it's something we should be more actively investigating to bring a message to patients that these drugs are actually effective and safe in these abdominal thromboses.
Lucia, you want to have something in addition?
It's probably not yet now. Yeah, so kind of everything's been said. But I agree, the hardest is when younger patients, especially children or very young ones, have such a large clot as an abdominal clot. And what to do lifelong on a special situation and how to manage it safely is pretty much the biggest challenge for all of us. And yeah, in a situation like this, for this specific subpopulation, there's really not solid data, we could make conclusion that everybody will feel fine about. And they probably and very likely will be changing down the road, but will we ever going to have enough patients alike with the same subpopulation that we will be able to actually make the conclusion? I do not know. So therefore, we try to put it as safe and as best as possible, but doesn't mean, as you asked, did she do something wrong when she had the event? No. Could we eliminate the risk to zero? No. So that is another thing that, well, everybody's just doing the best they could with the data we have or don't have to make it as safe, as effective, and as best for patients and everyone else. But there are consequences long term if they're not managed properly. And there has been so much information said about the clots and thrombosis. I think very important thing is recognizing the symptoms of the thrombosis and the events in patients as well as in the physicians, because we all had numerous patients that had repeated clots and nobody's really paid much attention to it. Or they had a clot and then nobody's addressed that. Nobody's changed the cytotoxic therapy, considered them perfectly controlled. And stuff like those do happen. And again, we all need to keep the education more, to keep the data up, and to spread the knowledge and educate, equally patients and the medical staff and everybody. These are the symptoms of the thrombotic events. This is something to watch for. If something like this happened to you, this is what we're gonna do, and stuff like this. I think that's a very important from both perspectives, because there's been saying that patients are, having symptoms, bringing the symptoms up, and they not being really listened to and said, oh, that's nothing, it just happens. And indeed, they had a serious clots or something like that. So those are also very unique and very, very complicated things that we all have to deal with, dealing with diseases like this. And given that a lot of these clots could be rare, like who would expect in a kid like yours having a massive thrombosis in the belly? Nobody. So that takes time to diagnose. People don't put it in a higher differential. They don't think about it. So it could come into the level that the liver fails before somebody starts thinking, oh, this is actually what it is. So there are certain situations that should be red flags for physicians and stuff, that if it happens in this situation, we have to rule it out. But it doesn't happen all the time. So, I had plenty 30-year-old male that have repeated heart attacks and nobody's put it together. Like, oh, your platelets are high, your hematocrit is high. Until they actually Googled it up and like, hey, my blood counts are not good, I should see a hematologist. And cannot even imagine that happens in a kid with a specific rare situation where nobody would expect that. Of course, then everybody would question, was there something we did wrong? No, but it takes certain level of suspicion and knowledge to really put that differential there when it's such a rare situation, and to really help as fast as we can. And that should and does include in this situation to really ask the experts. That could be a couple patients in the world. Have you seen this? What have you done? Because again, as we said, we don't have data we can easily bring up and say, oh, this is what has been done over the years and this is how it works. So we have to just all collaborate and bring the knowledge together, and even connect with somebody in Australia or wherever it is who has had similar situations to get the best knowledge. That was something that I wanted to kind of add to it.
Thank you very much. It's, whenever we talk about these things, there's one point which always comes up, and that's the information. We have, everybody, or you especially, and obviously when we as patients also, we have a lack of information. I think, every time we are more patients, we're getting more young patients, our groups are growing. So that information is available, but we have to get it. So I think it's one of the goals or one of the obligations of the patient advocacy groups, but we get that information from patients. So, this is one of the things which we are trying to do. And we are, for example, we have just started now a group of AYAs, pediatric and the AYAs. So there will be a meeting today. Go ahead.
Hi. Hi, everyone. Can you hear me? Okay, I'm also a mother of a teenager. He is 17. He was diagnosed at 14. And one of the things I want to focus is that it's a strange disease, it's a rare disease, but more rare in kids. So we, as parents, we front like a more big challenge, because even the decisions we take is not for us, because I can decide for me. But deciding for your kids at the time of taking a medication or doing some procedures or something, I think it's more complicated as parents. So when we face the moment or starting a treatment, we have a lot of questions, because kids are not small adults. Their bodies work differently. And I know it's a rare disease. I'm also a nurse, and I never had a patient with an APM. Now I have my kid. He is doing well. He started interferon in January because his platelets become 2 million. So we need to start. He also has the CAR mutation type 2. So I told him he is 1 in millions. And he says, yes, I'm the only one. So when we have to decide, we ask to the professional, to the hematologist, and sometimes their answers are, okay, we are going to try this, but there's no research. There's no studies. There's no something I can get in to tell you it probably works. So I just ask, please, we need more research, because there's been more kids, more. Here in Spain, we are, I don't know how much we are, but maybe, I don't know, 12, 15, 20, I don't know, that we know. But now with the new labs searching for platelets, we discover, and sometimes I know some people, it happened like my kid 2 years before he was diagnosed, I saw his platelets. Maybe I gave some importance because I'm a nurse, and I was 2 years telling to his pediatrician, my kid's platelets are not okay. And he say, oh, there's some infection, there's a cold, okay, let's do a lab in August. With the beach, with the pool, with everything, we cannot just say maybe some kind of infection. And his platelets were high. So at that moment he say, okay, let's go to see the hematologist. So what I'm telling just, we need more research, focus on kids and young adults, because we probably are not as much as the older people, but we are a lot. And as we cannot just extrapolate treatment, we are doing because we don't have any other thing. We just can do that because we don't have a study properly for kids. And thank you so much. I'm really happy to be here. And when you are like needing a light in the dark, I found the MPN Association in Spain and Peter. And it's really, really, you know, here in Spain we say, las penas compartidas son menos. And that's what I found here. So thank you so much.
Thank you. We have to keep in mind that, first of all, the physicians we have here, they're all treating adults. And there is a big difference if you treat your pediatric or you eat adults. What you say is absolutely right. And this is why what I started to say before is, it is our obligation, you know, like we made the group now with Monica, we're bringing all these Aya and young kids together. And what we have to do is we have to collect that information, but not only from Spain. We have to cut from the other countries also. And then that information we can pass on to the physicians, so that they can, together with us, we can start to talk to the pharmaceutical industry hey boys, not only adults, we also have kids. And obviously, when you have an adult, it's a problem of one person. If you have a kid, it's a problem of at least 3 persons, the parents and the child. So I think it's something which is, very emotional. It's very bad, for a parent if he has to do. And he, as you say, there is no information. You cannot get a guideline, but they can't. It's impossible for them because they do not have a basis, which is the information. So, this is what I'm saying. We are working tremendously in order to get somehow all accumulate that information the patients have. If we would be able to have experiences and results from 10,000 patients in Europe, this is a capital, and this is something which we could pass on to a physician and say, listen, these are the data which we have. And again, I only talk about quality of life, and I'm not entering in analytical data, but we're really, on this, And in order to show you how we are doing, and John, it will be your turn, so better get ready. We have a very close cooperation with MPN Spain and the foundation, together with MPN Stichting. This goes back for many years, and he has been working out a new system with a professional company, which is, I call it a tailor-made Facebook. So, that we can control much better the information which we are getting from the patients through the talks and through the input. Today, if you work in Facebook, what you publish today, tomorrow maybe it's not there, and after 3 days it comes back again. You cannot extract the information. So we need a tool where we really can say, okay, we got that data. We will have very soon a data for about 4,000 patients, but we should reach in about a year maybe 10,000. So when we have that, we really can get news. We can get a basis of information which we can pass on. And the same is for the young adults and for the kids. As was told before, Professor Kuchin from New York, I would say she is number 1 in pediatrics. And she was in Barcelona 2 years, and we started it, but it somehow didn't really go on. But anyway, we have now a new start with Monica, and I'm sure it will run. I'm sure you will have tomorrow some meetings also to launch it. So, this is what we want to do. John, are you ready to talk about MPN World?
Yes, if you want.
Yes, I want. Yes, I want.
Just talk about it.
No, you get a presentation. Is it there?
Just to introduce myself, I'm also a mother, 20-year-old MF patient, and just you can put a face, and we have the contact, MPN Spain. So for anyone that is ready to fight for the young ones, we are also ready. We don't know where to start with. We're a few parents in this meeting today. We'll be gathering tomorrow, and we don't know exactly which path we have to follow, in which direction, and what is our priority. Well, we know our priority. Which one is it? Our kids. But on top of that, just let us know, what do you need for us to give you to help us, our kids? So you keep saying that there's not research. What can we do to change that? We don't know. What information, what statistics, what numbers, whatever you need, just let us know, and we'll fight for that. Spain, Holland, Germany, France, Italy, US, Israel, and anywhere. Just let us know. Put us in contact with whoever you have in your hand that is also doing the same thing as we are doing, and we'll move it forward. I don't know. That's what I just wanted to say.
I think that one of the ways to generate knowledge in an area of such a ultra rare condition, an MPN in a child or an ayah, is to create a formal registry. I thought I was hearing things when Peter said he's got data on 4,000 patients through a Facebook. That's huge. But I mean, there are formal ways of collecting data that would be important. As you said, what do we need? Well, we need everything. We want to know everything, but we can't know everything. We can't know what the bone marrow looks like on an annual basis, for example. But there are registries for rare diseases, and this is a rare disease anyhow, and an ultra rare disease in a pediatric population. I would think the way to go about it would be to collaborate through patient advocacy groups and physicians that are associated with them to formalize an international registry. And that's the way to start, because there aren't going to be clinical trials, prospective clinical trials, on such a rare basis. But once you have a registry, then that's a way forward.
If I could just add a comment, and hopefully a ray of hope as well. Research in MPNs will benefit both adult and child patients. I have no question of this, and I think the fundamental research in terms of the biology of the disease is really key. But also the discoveries are going to make a big impact. So again, the calreticulin specific medications that are being tested, yes, they're being tested first in adults, and there are many reasons the pharmaceutical industry, there are many challenges in terms of developing therapies in children, no question. But all of these things, I think, really will make an impact. Now, several of the key questions that have already been asked here: why do people thrombose? Are there blood markers that can be predictive of that? Why do people progress? If we're using a medication to avoid progression, are we using the right dose, in a certain individual? So all of that will extrapolate. I do think what Martin had shared is key. That I think the two things that I think really will be helpful is, one, as organizations, and Peter really has taken the lead in this in terms of trying to at least bring people together who are younger with the disease, so we can really learn from that experience clinically. And two, over time, if there are blood and other samples that are really banked, that then when a discovery is made, then the question can really be made in childhood patients. Are they the same or different? First, we have to have a question. If there's a candidate marker for thrombosis, is it the same in children or it isn't? And it depends. There are diseases where teenagers are just young adults, and there are diseases where they are different. And to some degree, we don't have enough biology yet to really be able to separate that. I do think the teenagers, may be very different than truly very young childhood MPNs. But we may find that there is still greater similarity. The work from Dr. Nangalia in Cambridge, suggests that the MPN clone may be present even when the child is an embryo. And that, for some reason, it really activates mainly in adults, particularly as we get older. But we may find that, again, that childhood MPNs may just really be a variant of the adult disease, which may be very different than, some other diseases. But all of this other work, I think, will end up helping children as well. So don't view that there's no research being done. There's just very limited research that's specific only to kids. Just because the numbers are so small, it's just very difficult to do.